I was thinking of how to begin my talk, and I usually like to put in a few funny slides, and I didn't have anything. So I thought I'd start with something that is just a fact. I'm full of trivia usually. One of the apostles is actually buried in my hometown in India. And St. Thomas is buried about 10 miles from where I live. This is the Doubting Thomas for those of you that know the Bible. And I feel like we are a bunch of nutrition apostles here trying to spread the word around so that you'll carry our word all through the country and across the continent, because we're sending some of you to Mexico and Canada. So with that, no further ado, let's move on. First, I'm going to talk about the various components of energy needs. All of us have heard of basal metabolic rate. Diet-induced thermogenesis is what's going on in most of us since we've just eaten. Physical activity is obviously another component of energy, and I think for us, growth is done, but the patients that we take care of have growth energy needs as well. And as one can well imagine, energy needs may be affected by a variety of other things, such as your nutritional status, underlying disease, and so on. What is the basal metabolic rate? It is the amount of energy that you need when you're resting. And the way that we think about it and measure it is only in a clinical research center type setting. So you need to go into the hospital, spend the night there, they wake you up, and then they measure your resting energy expenditure. It is not practical, so people usually don't do the basal metabolic rate. What we do as a surrogate is the resting energy expenditure, which you've hopefully heard of and probably done in a few patients. Just like the BMR, it is measured at rest and in a thermoneutral environment, but we like to do it after an 8 to 12-hour fast. The most important thing is it is not necessarily after awakening. So if you can bring somebody in from home and just get it done, you're measuring an REE and not a BMR. These two are not different from each other by more than 10%, so the REE serves as a surrogate for the basal metabolic rate. Diet-induced thermogenesis, the way I think about it is I think about how people think celery has negative calories. And the reason, I don't think celery has negative calories, but the idea is that you spend calories digesting and absorbing your food. And this is what is thought of as a diet-induced thermogenesis. So it can be affected by the route of food administration. Obviously, if you're getting enteral nutrition, yes, parenteral nutrition, less. It is roughly 10% of daily energy needs. Sometimes people do resting energy expenditure studies in kids who are on continuous feeds, for instance, in the PICU. It's not meant to be done, but then you might have to add another subtract 10% of your energy expenditure if you're going to do that. I don't recommend doing that, but that's one way to think of it. Activity is important. In normal children, they are running around and spending a lot of energy doing that. But we also have to think of it in different terms in sick children. For example, the kid with spastic cerebral palsy might be spending a lot of energy just being spastic because the muscles are constantly spending energy being spastic. Or the kid with ADHD who's always up and on the go, spending tons of energy. The way that this can be put into an equation, I've just given you one example of one specific equation. There are equations for different ages and different levels of physical activity, right from sedentary to very active. As one can imagine, kids spend some of their energy trying to grow, and up to 30 to 35% of energy requirements in neonates can be spent just trying to grow. The second bullet is important in the sense that we always want to know how many calories per gram do you need in order to put down tissue. And this is roughly between 5 calories per gram in premature infants to about 6.5 calories per gram in adults recovering from anorexia nervosa. This can be used as a fudge to estimate how many more calories somebody might need in order to grow. Obviously, children recovering from malnutrition need extra calories in order to correct their growth deficits. And there are at least two ways to do this. One is to pretend like the child is on the 50th percentile for age, for weight and height, and then give them that many calories in order to get them to grow. The other is you use a calculation and then multiply it by 1.2 to 1.5 to get the number of calories that a child may need. The most important thing whenever you estimate energy expenditure is to see what that does to the individual child before continuing, because all of our measurements are somewhat inaccurate. As I've been stressing, energy needs can either be measured or calculated based on acceptable equations. These are some examples of equations. None of these is necessarily better than the other. They've all been studied in various scenarios, and in particular scenarios, some equations might be better than the others. The best way to actually assess energy needs in children is to measure total energy expenditure. Total energy expenditure is quite hard to measure, especially in children that are sick. We use a surrogate and use the resting energy expenditure as that surrogate. Again, we don't look after normal children and feed them either in an outpatient setting or an inpatient setting. All of these equations were established in normal children. So transferring that to sick children should be done with caution. This is a busy slide, and it explains all of the physiology that is needed to be known in order to understand how indirect calorimetry works. But I'll give you the gist of it. We know that if you oxidize carbohydrate, you get 4 calories per gram. If you oxidize fat, you get roughly 9 calories per gram, and so on. We also know that if you consume 1 liter of oxygen and put out a certain amount of carbon dioxide, how many calories you've sort of consumed. So if I took you at a steady state and measured every ounce of oxygen that went in and measured every ounce of carbon dioxide that went out and put it into an equation, it can tell me how many calories you have used during that period, and then that can be multiplied to give you an estimate for the whole day. The reason this is referred to as indirect calorimetry is because we don't put you in a room and actually measure how much heat you're producing. So since we are doing this indirectly, it is known as indirect calorimetry. Moving on to protein. In an adult, skeletal muscle is roughly about 50%. Whereas if you look at the last part of the first bullet, it says brain, lung, heart, and bone is about 10%. This, from our perspective, because we take care of children, the younger you are, the distribution changes. Kids have big heads because their brain is relatively large. They have far less muscle. So they have a lot more protein contained in their brain and viscera. There is a concept of a labile protein reserve, which can serve as somewhat as a bridge. You eat well today, you may not eat as well tomorrow. So you can use some of your protein from within your own body to tide over that time point. The problem is this is not something that's sitting there waiting to be used. It is still functional protein that you're going to lose if you consistently keep using that 1% and don't replenish it. You are still going to be using functional protein. So you don't really have a protein reserve. And even in the absence of protein consumption, nitrogen continues to be lost. And these are the basal protein losses that have to be lost every day. Roughly about 10% of both indispensable and dispensable amino acids will be lost if the diet is devoid of protein. Again, as we can imagine, the preterm infant synthesizes a lot more protein per gram per kilo than an adult. This is something that you should just remember. It is mostly clinically irrelevant to us because the essential amino acids are not something that we worry about very much, because hopefully we are all eating balanced diets. All of our formulas and all of our parental nutrition contain all of these amino acids. The places to think about them are when you worry about the conditionally indispensable amino acids. Some of these are necessary in the term neonate, with more being necessary in the preterm neonate. The other concerns, such as arginine and glutamine, they are thought to be conditionally essential in critical illness, even outside neonatology. Finally, moving on to protein deficiency, this obviously affects all organs. In infants and young children, they're growing. They also have a lot more protein in their brain. You have harmful effects on the brain and may have long-term effects on cognition. There are also adverse effects on the immune system, resulting in a higher risk of infections. Since gut function is affected by protein deficiency, there is possible gut translocation and therefore septicemia. It is important to note that adults will die in about 60 to 70 days if they're completely starved, as some of those IRA men showed us about 20 years ago, where they ate and drank nothing and they died in about 2 months. And a 1,000-gram neonate doesn't have that much time. It's only 5 days. So this is why they get TPN much faster if they're not being fed at all. How do we assess protein status? One relatively simple way is to look at the mid-arm muscle circumference. It will give you a sense of the protein status, provided the kid does not have a myopathy or a neuropathy. It is helpful to follow this over time, understanding that you have to have at least about 4 weeks in between measurements. The tricep skin fold gives you a sense of your energy nutritional status. And remember that serum albumin is an extremely poor indicator of protein status. It is useful prognostically. If you come into the hospital and you have a low serum albumin, you're much more likely to die over a variety of clinical scenarios. But this is not because you are malnourished. It is because albumin is a negative phase reactant, and if your protein is low, it just tells you that you have a very high CRP or something else, and therefore you're more likely to die. Moving on, what is starvation? Because I'm gradually going to move on to starvation and then talk about refeeding syndrome. We all use carbohydrate metabolism. We eat, we use the glycogen to produce glucose, and so on. First one, if you're not eating at all, the glycogen reserves die out pretty quickly. You move on to fat and protein catabolism, and then you use glucose and ketones for energy. As you start losing your muscle to produce energy, you also lose muscle from your heart. And this causes myocardial atrophy. It makes you more prone to heart failure and more prone to arrhythmias. The liver wastes away with decreased protein synthesis and further alterations in metabolism. The GI tract, I already spoke about this. It causes malabsorption and dysmotility. It worsens your malnourished state and makes you more likely to get infections. The kidneys lose their ability to concentrate urine and makes you prone to diuresis. There is an intracellular loss of electrolytes. Our favorite three with regard to refeeding syndrome: potassium, magnesium, and phosphate. And insulin secretion decreases because insulin is an anabolic hormone, and the BMR slows down to 20 to 25% in an effort to conserve energy. So you become bradycardic, hypothermic, and hypotensive. This is what the WHO would like us to classify malnutrition as. And remember that rather than Kwashiorkor, they prefer the term edematous malnutrition. And if you have edema in the context of malnutrition, that automatically makes it severe. If you don't have edema, then you look at the second and the third rows, and it's based on either your weight for height, if you have acute malnutrition, or height for age, if you have chronic malnutrition. And if your z-score is between -2 and -3, then you have moderate malnutrition. And if it is less than -3, then it is considered as severe malnutrition. Like I said before, don't use the term Kwashiorkor. It should correctly be termed edematous malnutrition. And even though we were taught in medical school that marasmus is this kind of deprivation and Kwashiorkor is the other kind, more research has shown that nobody knows why some kids develop edematous malnutrition and why some kids develop marasmus. Moving on to refeeding syndrome. It is a term that describes the metabolic and clinical changes that occur upon aggressive nutritional rehabilitation of a malnourished patient. It was first described after World War II in prisoners of war, and the term was given to the cardiac and neurological problems that occur upon refeeding. In answer to somebody's question from yesterday, it normally occurs within 3 to 4 days after initiating feeds, but unfortunately, it has been described for up to 2 weeks after initiating refeeding. So that's something to remember. Symptoms include a vague but long list, which includes the neurological system and the cardiovascular system. And phosphate depletion is the hallmark and the cause of the majority of symptoms that are associated with refeeding. Let's look at the pathophysiology. I will skip the first 2 little pieces here and move on to refeeding, where we've switched to anabolism. We are giving this child fluids, salt, and nutrients. Remember that if somebody is very malnourished and you decide to give them D10 as an IV fluid, that can precipitate refeeding as well. It's not just feeding them either enterally or giving them parenteral nutrition that gives rise to refeeding. Insulin is then secreted from the pancreas. It causes increased protein and glycogen synthesis. This then causes uptake of glucose, utilization of thiamine, uptake of K, Mag, and Phos, and this then leads to hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency, and also salt and water retention, along with edema. Where do we need to think about refeeding syndrome? I think we're all pretty good at looking for it in severe malnutrition. And if you do manage anorexia, folks, then you should be looking for it in anorexia as well. But one place to think about it where it's not intuitively obvious is in an obese child who has lost a lot of weight. So think about it there as well. And the other is if you do have kids who have spent 7 to 10 days in the hospital on just IV feeding, and somebody has suddenly decided to give them parenteral nutrition. One other study suggested that in a child, if your calculated ideal body weight was less than 80%, calculated body weight was less than 80% of ideal body weight, that was a risk factor for significant refeeding syndrome. I think we've already gone through this, so I will skip it, but this is important for your boards as well as for the rest of your life if you're going to be doing any form of nutritional therapy. Just to go into phosphorus a little bit more, phosphorus is ridiculously important in metabolism. Without phosphorus, we'd all be blobs who wouldn't be able to do anything, since it is a vital constituent of ATP and 2,3-DPG. During refeeding, glucose intake leads to insulin surge, pulling phosphorus intracellularly and leading to defects in both intra and extracellular phosphorus levels. Also, since you're trying to get things going, there's an increased demand for and utilization of both 2,3-DPG and ATP. When I spoke earlier, many of these children who are significantly malnourished also have cardiac muscle atrophy, and they're highly prone to developing ventricular dysrhythmias and sudden death. So that's something to remember. Potassium sort of follows the same route as phosphate and is driven intracellularly by insulin. And if you get hypokalemic, you're again going to have cardiac arrhythmias and cardiac arrest. Magnesium is important both for the heart and for your brain, so hypomagnesemia leads to problems in both of those areas. If you decide to give this malnourished child a large amount of glucose other than the classic refeeding syndrome, they get very hyperglycemic. This can lead to osmotic diuresis, dehydration, acidosis, and ketosis as well. If you do this in the ICU, for instance, they can get fatty liver disease because of lipogenesis. They produce more CO2. You're not able to wean this kid off the ventilator. So that's another reason to not give people too much glucose when they're malnourished. Finally, this is important. Carbohydrate intake leads to a rapid decrease in renal excretion of sodium and water. So the kids that were diuresing suddenly decide to hang on to fluid. And if you decide to keep their urine output normal, quote unquote, they can then lead to fluid overload and another reason for cardiac failure. So it's important not to be overly aggressive with fluid rehydration of malnourished patients. What are recommended? Identify patients at risk of refeeding syndrome. I think if you do this, more than 80% of your battle is already won. Before you initiate your feeds, check your electrolytes, including potassium, calcium, phosphorus, mag, BUN, and creatinine. Start refeeding at 50 to 75% of goal calories and increase to goal over 3 to 5 days. I think the general sort of consensus is the more malnourished, the slower you start and the slower you advance, and the more often you check the kids' labs. Protein does not need to be restricted. Rehydrate carefully, being careful not to fluid overload, and monitor all of your labs frequently during the first 4 days and replace appropriately. There is a thought that if we used what the WHO does, we could prevent a lot of the refeeding syndrome. What the WHO does is they have 2 mixes of food which automatically include multivitamins and multiminerals. Unfortunately, those are not readily available here, and I'm waiting for somebody to do a study where we put those multiminerals in our Pediasure or whatever your favorite formula is and show that we can pretty much eliminate refeeding syndrome. It will take refeeding syndrome off the map, if you will. These are replacements suggestions. And in general, it is probably best to replace a multivitamin, multimineral, give them a multivitamin, multimineral supplement. We typically give it orally. The thiamine deficiency has been classically described in alcoholics. I haven't seen reports from children. And in very significantly malnourished children, iron is usually not given during the initial phase. So malnourished patients have altered metabolism. Patients are severely intracellularly deficient in several electrolytes, including phos, potassium, and magnesium. And aggressive refeeding in the initial phase and rehydration can prove deadly if you do not anticipate, correct, and monitor carefully. So start low and go slow should be the mantra. And I think that is my last slide. I have a polling question. So let's see if this will work. This is cool. This is, one would think that this is like the audience question and who wants to be a millionaire, and people don't seem to be swayed by the maximal response.
The total results are listed in the lower right. So far we can see there are 16 that have registered so far.
I think we can call this off. Surprisingly, there are studies of the first 3 which show that these kids all have normal albumins. The kid with spastic CP, the kid with HIV and growth retardation, child with marasmus and anorexia nervosa. If you are in the PICU, when you go back home, go and look at the kid with a significant traumatic brain injury. The odds are that that kid is producing a whole bunch of acute phase reactants and has decided not to produce any albumin for a while. So that's why that kid has a low serum albumin. Okay? So this is something to remember.